surprised to learn that the the local clinic, was 2 blocks away. And we went to see the physician who arrived on a motorcycle and did extensive testing right in his office, blood testing, EKG, the whole works, and physical exam as well. She was given a medication, asked to come back the next day. She met with the physician's brother, also a physician, who went through a very detailed report for her, identifying what she needed to do, and sent off a referral letter. It was just exceptional service. When she got back home, of course, she went to her GP immediately, but over time, she began to feel increasingly unwell, weakness in her legs. And so she was pursuing this issue, and eventually was referred to rheumatologist. But before that, she had an emergency crisis where, again, heart palpitations. Her doctor told her to go to ED immediately. At that appointment, she had a very poor response from the emergency department, was treated with great disrespect, and really was questioned why she was there, although she had been referred by her physician. That ruled out that she wasn't having a heart attack, which is what she was worried about, or there was immediate heart crises. So she went back and awaited a referral to a rheumatologist. There was a year delay, and she had increased disability, pain with walking. She golfed, so she was unable to swing arms. So her arms, that was an activity that she had to discontinue. Next slide. So in the time that she was searching for a rheumatologist, she finally got an appointment within a month. And the rheumatologist did extensive testing, including genetic tests, HLA, B27, which turned out to be positive. Now, the medical people online hopefully will know what that means. It was new to her. She was also tested for C-reactive positive, so evidence that her immune system was compromised. This ended up being a benefit in terms of COVID when she did get COVID, because she was able to have Paxlovid as a treatment immediately. The first consideration was a diagnosis of psoriatic arthritis, which is very commonly confused with the eventual diagnosis that she did receive. She had a history of eczema and different skin conditions, so that was a part of the diagnosis. Excuse me. I personally am recovering from COVID, so I'm struggling a little with my voice. Sorry, my apologies. So finally, we arrived at a diagnosis, Anglo-Sing spondylitis, which is family history discovered with HLA-B27 gene in other members of the family. So she began her treatment plan with the first line of therapy and moved to biologics within 3 years. Next slide. So the impact of this lengthy diagnostic process was, of course, she's a young woman in her 30s. She was anxious, and she lost confidence in herself and her own well-being. She had increasing disability and fear that treatment would never be found. She had frustration waiting for a referral to a specialist as symptoms worsened. Could I end up with no mobility was a question in her head. Could I keep working? She's an executive, so this was a bit in the middle of her, prime of her career, so a great concern. Also, she felt no one believes me, and that was certainly the experience that she had at ED and with other professionals along the way, experiencing rude and dismissive responses. Her final diagnosis was a relief. Options were provided, although it was a very devastating diagnosis for those who are not aware of the disease. It is rare. Something like 1.4% of the population has this disease. It's more apt to be men, twice as likely to be men. So she was in a small group of people. And what she learned in terms of the conditions for her heart is that the disease can impact different parts of your body, and it was her heart that was being infected or inflamed. And that's why she was having episodic heart palpitations. She wasn't having a heart attack or a stroke. This is a part of the disease component. So with the disease diagnosis, she was able to understand management process and, more importantly, able to explain to others, her family or friends, and also other medical providers. Next slide. So overall, correct and timely diagnosis is so important for the patient and family. Builds trust, gives patient a direction to manage the illness and mitigate the risk, builds confidence, even if you're dealing with a serious diagnosis, which of course both of us were, puts patients in charge of their life. It's beyond the medical condition. It's your entire life you're trying to manage. Encourages other medical practitioners in supporting the treatment plan, and helps with communication across systems and sets the right priority level of treatment, and respects the needs of patients and their wish to live an active life. Thank you very much.
Thank you, Joan. I think, first of all, it's quite a comparison of experiences Joan has had. I think one is very clear treatment pathways in our diagnostic pathways leading to clear treatment outcomes. And the other one is diffuse diagnostic pathways in which there's lots of different tests and taking a while to get to a diagnosis. And you hear a lot about in that pathway fear and anxiety, and also the level of that fear and anxiety changing with the type of communication that happens with the medical professionals. And I think that's such an integral part of the diagnostic journey about having the patient not just as a patient, but as an active participant and as a partner in this, and how you speak to your patient and how you understand the journey they're on is something that's really critical in increasing this patient safety. So the next part of that journey that we're going to be discussing is Dr. Sanfilippo. And he's been a clinical cardiologist with the Hotel Dieu at Kingston General Hospital in Canada. And he's directed electrocardiography laboratories in both locations. He's also had teaching positions with Queen's University, and as a professor of medicine and cardiology. His major clinical interest has been electrocardiography. He's been published numerous articles and conducted research in electrocardiography, vulvar heart disease, and cardiac research in women. Today, he'll be describing the impact of reduced access and poor integration of diagnostic services on patient care. He'll propose strategies and best practices for managing integrated care transitions and enhancing continuity to improve patient care. And I just remind you, if you have questions, put them in the chat and we'll address them after. Thank you.
Well, thank you, John, for that introduction. And I must say, it's a pleasure to be able to join so many colleagues from so many parts of the world. It's wonderful to be able to come together this way and to talk about what's so important to us, and that is the care of our patients. And that care involves providing the right diagnoses, the right treatments in the right place and the right time, and making sure that they're accurate along the way. And we just heard a really compelling account of what that journey can look like from a patient perspective. And as those who provide that care, who are so wrapped up day to day in the mechanics of providing care and the specific things we do, I think it's important every once in a while to stand back and to consider what it's like from the patient perspective. And so I'm going to try to do that from the point of view of someone who works in the system, as all of you do. So if we can just go on to my first slide, what I'm going to do is try to describe the challenges in providing care to patients with important but non-urgent medical problems. I'm making that distinction because I think we across the world do a really good job when patients are in life-threatening conditions. Where things maybe don't work quite as well is when the problem is not immediately life-threatening, but nonetheless important or chronic. And I will be speaking from the perspective of our situation here in Canada, but I think the principles will apply everywhere. I'm going to explore the consequences of our care delivery system, and then maybe suggest some blue sky kind of proposals for how we can rethink things. And again, every once in a while, it's important to stand back and just imagine. So let's just go on and to the next slide. And I'm going to talk about a patient journey. Okay, so I'm going to talk about a woman who is a 45-year-old accountant. She's a bright, engaged, active, busy woman. She's been generally healthy through her life. She has no chronic medical issues, but has been troubled for the last month or more with abdominal discomfort. So she's been having this low-grade abdominal pain that's getting worse, waking her from sleep at night. She's been trying antacids, hoping that that'll go away, and they helped a little bit at the start, but they're not helping much anymore. She knows she's under a lot of stress. She wonders whether that might be part of it, but the point is it's getting worse. It's not getting better on its own, and she needs help. She knows it's not something that she needs to go to an emergency department about, but it's also something that's just not going away. And so she's looking for help. So she is fortunate enough to have a family doctor. And next slide, please. So she makes a call to her family doctor's office. And I'll just point out that in Canada here, she's one of the lucky ones. 15% of our people in Canada don't have a family doctor, so don't have this access. But she's able to call her family doctor's office. She speaks to a receptionist who gets some fundamental information, tries to sort out how urgent this is, and after a bit of conversation, gets an appointment 2 weeks later. So 2 weeks later, she cancels her day at work, parks her car, and comes to an office. Next slide, please. That looks kind of like this. So she sits in a chair in a family doctor's office, and there's an examining room and a place for the doctor to speak to her. And she meets her doctor, and over the next little while, relates her problem. Next slide, please. And there are, when you think about it, 4 possible outcomes of this encounter. One outcome is that the doctor may recognize right away what the problem is, have a solution in hand, deliver that solution, and resolve the problem in that visit. That seems unlikely in this scenario, but it's theoretically possible. It's more likely that more testing will be required. It's also possible that the doctor may feel that consultation to a more specialized physician might be required. And finally, the doctor may think about this and realize this is an urgent thing, needs to be dealt with right away, and just send her to the emergency department. So those are 4 possible outcomes, but I list them because the setting in which our patient and doctor find themselves is suitable only to one of those outcomes. It can only fully address one of those things. The other things are all going to require more assessment. So let's just go through that, what that more assessment looks like. So our patient, Sarah, next slide, please. Say she needs blood work. Well, that blood work, she needs a requisition for the blood work, which the doctor will fill out. She needs a separate appointment to get the blood work. The results have to be analyzed, go back to her family doctor, and then some follow-up has to be arranged to see what the blood work showed to decide what next need to be done. Sarah might need an ultrasound. She probably needs an ultrasound. Well, that's another test, another place, another doctor, another assessment, another technologist, another results back, another follow-up. She might need a consultation or a procedure, like an endoscopy. Well, that's yet another requisition, process, prep, people to talk to, different place, different appointments, time, interpretation from another doctor, an interpretation back to the original doctor, and some consultation back to Sarah. So when you put all this together, this next slide, please. We've got our patient Sarah running through a maze of separate, probably well-functioning, but very separate, very unintegrated encounters with medical diagnostics in order to resolve the issue that she came with. And every step delays the resolution of the problem. Every step requires individual paperwork of some type or other. Every step generates results that are the form of which and the delivery are unique to the source. So they run independently. So what are the consequences? Well, some of these are obvious, right? It's inefficient. It takes time. Um, it delays the diagnosis. It's expensive because every one of these things is a separate source that requires support, requires staff, requires billing, requires building, all that stuff. It's a lot of work. It's a lot of work for everybody. You know, Sarah is taking a lot of time to do all this. She's missing work. Her condition could be getting worse while all this is going on. It's also a lot of work for the doctors involved. The family doctor, the original family doctor, is having to keep track of all of this stuff that's going on while Sarah is going through these processes. But really importantly, whenever there are multiple disintegrated components like this, there are multiple potential for sources of error. And we struggle mightily to ensure that every diagnostic process has standards associated with it, has processes, has assessment, has accreditation. But anytime we transfer information and instructions between separate sources, there is a potential for error. And all this impacts both patients and providers. And importantly, it's self-propagating. And by that I mean that as we get into this process of having separated delivery systems, we need more as our technology increases and our ability to do things. We have new procedures, we have new diagnostics, we have new tests, we need new ways to do it. And rather than bringing them into existing structures, we have a tendency to build new ones every time. And so our system becomes even more separated. Next slide, please. So imagine if we, sometimes we talk about blue sky imagining, just pretend we didn't do anything. Imagine that we were starting from scratch. What are we talking about that needs to be provided? We're talking about non-urgent medical issues, things that aren't immediately life-threatening, that require sirens and an emergency room visit and immediate surgery, but things that are important, that aren't going away, that are impacting patients' lives, that are causing them to suffer, and that if left alone will cause what may build into those sort of emergencies. We also have a need for continuing care of chronic problems. Our population is older and older, and that means that they have more and more issues that require monitoring. And again, these aren't emergencies, but if we don't pay attention to the rehabilitation from surgeries or the care of diabetes or the care of people with renal dysfunction, those things are going to escalate. And we have an incredible need for preventive care. We're good at dealing with the consequences of illness. We're not nearly as good at preventing it from happening. We will fix your hip if you break it, but we're not nearly as efficient about assessing your calcium, your bone structure, and preventing those hips from breaking. So what could change? What's possible to change? Imagine what could change. Well, as we pointed out, we don't always have the physical structures that allow integrated care to occur. We're separated. We're not physically close enough. Our services aren't integrated. The computer system that assesses blood work in a peripheral lab, or that generates reports for an echocardiogram or an ultrasound, is done in a separate system, a separate computer-based system that may or may not, well, probably won't talk easily to the system that Sarah needs to have everything come together. So our information access and transfer is poor, and we need to focus on Communities. We need to realize that our patients live in communities. They live in places where they need to connect with each other. They need to connect with care. They need to know where to go. And they don't need to, it's a barrier if they have to belong to a particular doctor in order to get care. Again, the model of acute care may be something that we can use to help us. Next slide, please. So an observation that we've been making all along is that we don't seem to have nearly enough of these problems when we're dealing with acute life-threatening illness. When someone shows up to emergency departments with a crisis of some type or other, we're able to somehow magically clear out all that pathway. We're able to integrate our systems. We're able to bring together things efficiently and quickly. And why do we do that? Well, we do it because we have hospitals. Next slide, please. And if you think about it, you know, what is the hospital model and what allows it to work? Well, it has a purpose. A hospital, as they've evolved, weren't always this way, but they've evolved to be places that provide acute and complex care as their primary mission. Now, I'm pleased to say that isn't their only mission, but that is their primary mission. How do they do it? They do it because they have central oversight, central governance. They have funding that's global, that says, look, you take care of these problems in the community. We're not going to tell you how to do it, but we expect that your people are going to be well served. We expect that folks are going to get their heart attack dealt with quickly, and they're going to get to care quickly if they have a catastrophe. But you figure out how to do it, and you have governance structures to make sure they do. They have services that are integrated and staffing that are relevant to the central purpose. In other words, the systems within a hospital talk to each other. You can get access to those investigations and lab work, all that stuff quickly. The people are integrated. So they have data management and they have ways of people talking to each other. And really importantly, it's an open resource. Okay? You don't have to belong to a hospital. You don't have to belong to a particular doctor. It serves the community. It serves who walks in to the community. And as such, it can provide services to the broader community that otherwise wouldn't be able to be provided. Primary care, preventative care, rehabilitation services, services to do with social issues and such can all be provided in the same model. So next slide. So imagine if we had the same model, only instead of limiting it to that acute care, we said, okay, we're going to use the hospital model to address our need for non-urgent care, continuing care, and prevention. And just think about that. You know, think about having this purpose that's now integrated with central oversight, governance, and integrated process, where we turn our attention not just to make sure the patient lives the next 24 hours, but make sure the patients in our community are well served with respect to risk modification and chronic care issues. Next slide, please. What might it look like? Well, it might look like a community structure that has a variety of different services with a number of things that relate to the needs of our patients. If you think about this, not in terms of how it would work for us as providers, but how it works for the patients in our community who need care. Well, you think about assessment centers where people can be seen either personally or virtually and have an assessment and triaging function in terms of what they need. Right now, patients are triaging themselves. They're deciding themselves how urgent their issue is, or with the receptionist on a phone. It could have a diagnostic center that has multiple diagnostics available in an integrated fashion, rapidly delivered to physicians. We still need those interview rooms and examination rooms, but they're in a setting where the doctors there can access, other doctors can access care. They would have all these other things I've listed here that serve the community with the idea of providing continuing care and preventing disease as well. And they would be, they could look like malls on the first floor, where people gather, where older folks gather, where people get services, where they can pick up things they need. And they can come together, because we know that loneliness and the lack of social interaction is a huge issue in health as well. Next slide, please. So I am just going to employ my final message is, you know, Steve Jobs years ago told us we need to think different. about computing and how we think about information transfer, how we think about talking to each other. And my plea here is that we think about developing structures and processes that meet the contemporary needs of patients and providers to provide safe, efficient, and economic care. So I'm going to stop there, John, and I'm happy to come back and chat and hear questions later.
Well, thank you very much. I think having heard from the patient perspective of the challenges of increasing diagnostics, and now from the physician perspective of how managing these diagnostics becomes logarithmically more complex. And with each diagnostics, we've seemed to be creating more silos instead of, more communities. And the proposed structure of taking what works well in the acute care center in the hospital and taking some of those principles and moving them into the community or community setting in order to help break down those silos, as well as provide a better patient experience. And I think that's really an interesting idea and how that would occur. And so thinking about that infrastructure maybe in a different way, and some proposals is our next speaker. Jacques Federspiel is the Chief Information and Security Officer at Hôpital Robert Schuman in Luxembourg. He'd spent over a decade leading healthcare IT and information security teams with several innovative projects. He is also a member of the Validation Commission of Accreditation of Prior Learning and Experience, called the VAE in the Ministry of Education, trainer at Lifelong Learning and Luxembourg Center. He is also a trainer teaching safer, responsible, and positive use of information technology for children, young people, parents, teachers, and seniors. So today, Jacques will be discussing numerous advances in Luxembourg's healthcare landscape that benefit patient care, including improving diagnosis and treatments, and a better understanding of disease and effective preventative measures.
Okay, schönen guten Abend aus Lützeburg. Bonsoir de Luxembourg. Hello. We heard now from Anthony about integration. What I will show you up with this initiative that we have here in Luxembourg with this data space for health is how we see the future, how we try to create an ecosystem at the end to have this exchange of data and a better healthcare view. Next slide, please. To explain you a little bit the wording and what we are doing about this, first I have to explain, perhaps not everybody knows European Health Data Space. It is a European Union initiative aimed to improve healthcare research and policy through better use of health data. So to create, empower individuals, promote research and innovation, and improve the healthcare delivery. EHDS impose also several obligations to the EU countries. These obligations are designed to ensure a better and properly function, and to have at the end also from the data privacy side and from the secure use of health data side a better view. So it's a model that is at the end delivered by the EU Commission. On the other side, we have Gaia X. Gaia X is an European initiative aimed to create a secure, federated, and open digital infrastructure, so a framework at the end. And the principle is, at the end, GAIA-X aims to create a digital ecosystem where data and services are more open and interoperable and secure, and giving them control from Europe inside. So it's the answer to the cloud system at the end that we have from America or Asia. So Gaia-X is not technically a cloud system, but it's a framework at the end that can be installed wherever you want. So you have on the one side, you have the AHS regulation model, and under this, at the end, you have the technologies that you have to build up to try to respond to this model. Is Gaia-X mandatory for AHDS? No, it's one of the models that exists. You can also do other solutions at the end, but we at this moment go this way. Next slide. So we don't see that all the data are centralized in one point, but we see more and more, and that's also from Anthony's side, data is wherever you want, you have data. The problematic today is how we can interconnect this. With this Gaia X model and with the model that we try to put in place is, from our point of view, make an ecosystem where we interconnect at the end existing data spaces with new data spaces at the end, not only in Luxembourg, but also over the frontiers at the end, but with the same languages, with the same regulations, and at the end that you have just to do one time this initiative, that you don't have to do one by one each time the problematic of privacy, or the problematic of authentication, but really based on use cases that you can exchange data and that you have the data on a need-to-know principle. Next slide. So this project at the end is a European project at the end. It's also founded by the European Commission at the end. It's a 2-year project. And it's not, at the beginning you say, okay, it's a digital project. But at the end, what we focus on this project, not only the digital part of the journey, but also what do we need to change on the regulation side, and more important, from the care side, can we use this model at the end? Is it usable on the field at the end? And for doing this, we put also in this project 2 use cases, one on the diabetes and one on the oncology side. I will explain this a little bit later. Next slide. So for doing this, we are not alone. At the end, we are a consortium of partners. We have at the end, when you see from the left to the right, we have the Luxembourg Institute of Health. That's at the end is the research center of Luxembourg. At the end, we as hospital, we have our project owner, that's the digital partner that we have, that's entity data at the end, and we have also the university. So we are the consortium leaders, but we also work together with other initiatives that we have, like eSanté. eSanté is the valid from, we have in Luxembourg the principle that you can, as citizen, have a valid with your patient data in your own access. That's the eSanté side. And what we also have is LNDS. LNDS, what is the principle is that each country has to establish a national health data access body. So LNDS is at the end this institute where you can where data can be exchanged in the same way, not only on the healthcare side, but when you want from the finance side, exchange with the automotive side. So LNS is there in the middle. And we have also like LNDN, that's the laboratory, the National Laboratory of Luxembourg. So we have at the end a consortium of companies from the primary use to the secondary use, from the legal side, all together. Next slide. So the project itself, what I said before, is it's not only from the business, for the medical side, it's not only from the technical side, but it brings all this ecosystem together, that at the end we have really something, at the end it's a proof of concept. At the end we will have, at the end the result, will it work or will it not? That is the question. We are really convinced that we will do it, but at the end, you have often also on the legal side often problems or the acceptance of the people. But that's the challenge that we have for this 2 years project at the end. Next slide. So the project itself is divided in some work packages. One more dedicated on the business side. One more dedicated on the legal way, how to what legal aspects do we have to consider from the baseline now. The technical one is how we can interconnect existing and new systems at the end. Also, one thing that is important is we want not to push out systems. The principle is here to create an ecosystem, and if somebody wants to make a connection on, we are open on doing this at the end. So we have at the end also in the project itself, you will see that on one side you have the primary use of data, on the other side you have the secondary use of data. In the project itself, here we are just focused on anonymized data, but the end product will be the way how can you at the end, when you speak about digital twin for the future, how can you from primary data to secondary, how can you cycle this data at the end? And at the end, how can we bring this in the existing ecosystem? And one thing that is important is how can we, from the process side, on the field, from the doctor side, from the patient side, from the care side, how can we implement it that it makes sense and at the end it's a gain for their business. Next slide. So the skills that we deliver from the hospital sides are clearly defined. At the end is we have the knowledge from the medical and the care side. We know the processes. We know how our ecosystem on our side works at the end. So what our mission is at the end is to say what is the as is today, what are our expectations for the future, what are the new things to coming in, but also when we go direction AI models that we also validate it, that are not that at the end the researchers are doing things that are technically super, but that at the end it makes sense for the medical care and for the medical and the care side at the end, and that we have at the end an ecosystem that we can use. Next slide. So based on what I said, it's a digital project what we put into medical use cases. One is based on the diabetes. So what we focus is at the end to create digital twins for making the decision. So at the end, the principle is next slide. The principle is how can we treat patients on the diabetes side? So the journey will be is when a patients come to a doctor, there are vital data, there are basic data that are be taken from the patient, if it's a new one or an existing one. And these data are directly transformed to secondary use. For this, we need at the end pseudonymization of the data because we have to go back with the data. On the pseudonymization side, data is put then on the digital twin model at the end. And the principle at the end is from this digital model, the doctors get back a decision support software at the end that helps at the end for new patients, but also for existing patients to treat them, especially on some diseases or some changes about this. So the digital model that will be created with our colleagues from the university at the end and also from LEH, we put data from existing patients, how we treat today the data. So we have this baseline. We have from external sources data that we put in. There are biomedical data that we put in. There are also the way on having imaging data. So all this model at the end will be created and based on this, giving an answer to the clinical decision. Next slide. The second use case, that's on the oncology side, and that's on the lung side. Today, the treatment in Luxembourg is really clear. Normally in the hospital, when the treatment is done, is completely separated from the research. There are diagnoses are made for the patients. There are some treatments that are made on it. And what happens then, these data sometimes for projects are anonymized or sometimes pseudonymized, depending on the project. And then the research side and the secondary use, they can do then their job on trying to find new way to do new care models for the oncology cases. So what we will create here at the end is an evidence-based system. What will this mean at the end? That we very close together from the primary use side with the secondary use side, that we have a direct connection, a secure connection at the end, and also a validated consent-based concept at the end, that directly the data from an oncologic patient at the end can be transferred to the secondary use side, and that directly from evidence from the translation can directly be implemented to the primary use side. So that the doctor can, the way of diagnosis, change ways to treat it, can consider new ways of what happens around us in the world, because we are not isolated at this moment. And at the end, that we have a better patient view on the patient care. Next slide. So on principle, what I want just to show you today is that the ecosystem framework that we will create is not only from the digital side, it will also consider on the legal side, what do we need to change on the legal side? Do we need to have new or adapted reference model? How can we use primary and secondary data? But each time on the base, what I said to you at the end, that everything technically based is on the framework from Gaia X, and in alignment with the need of the AHPC model on it, and also that the model can be duplicated. Duplicating at the end will mean that we are now having this use case on the oncology and diabetology side, but also that we can use it at the end for other diseases at the moment. And for this also, we are really open also for the audience at the end, if they have new ways or or if they want to have some information about us, where can you find information? Next slide. So we have our presence on the internet data space for health.lu, but we are also on LinkedIn, where we share all the information that we have. And we are, as I said, open also for people that will join to speak about us, to exchange about what happens. And that's a little bit what my final word on this is that from the patient side, you have a lot of view. For me, it's at the end, you have to work together from the patient side, with the doctor side, from the healthcare side. It has to be this triangle that we have all together to work. And the only thing I'm doing this is not only on the national view, but also on the international view, where really it's going on with AI system, with cloud, and so we are no longer locally, but it's an ecosystem, it's a large family. And at the end, the principle is clear. We are all working together to help the patients to have a better patient care. And next slide. And that was it. Thank you very much.
Thank you very much. I think today we have so many new diagnostics, and as we heard, I think from a physician perspective, those new diagnostics can create silos, and those silos potentially interfere with how quickly we can address patients' diagnosis. And I think, hearing about the physical infrastructure, but hearing also about how AI and technology can help bridge those silos, I would say, electronically, and having to think about things from a digital perspective, and the legal considerations, and having a framework to do that. I think what's ideal is, someone had commented in the chat, Luxembourg is a relatively small country, and what an ideal place to test things out and really develop models that can be then learned from and extrapolated to other countries. We can learn so much from that. So I really appreciate you bringing that together and thanking you about talking about sort of the IT aspect of how we can bridge this in today's modern era. So I encourage everybody to put questions in the chat. I know some people have. I think we're going to move to the Q&A portion of this. I did want to just briefly summarize a couple of things before we move to questions. I think what's really important about this, the first thing, and I really admire Joan for coming forward and not only bringing her story, but being so heavily involved in being a patient surveyor, is that, I think the patient, we keep coming back to that, is such an integral partner in this whole system. And the patient isn't partner, and it's a great quality assurance mechanism. Everything happens around the patient and with the patient, and how we communicate with the patient and how we treat the patient. And that's the lived experience, and that's their experience. And so, as we think about surveys and Accreditation Canada, and we think about the patient perspective is such an integral part of how we assess the delivery of care and that information. And I think, I think hearing about as we always are championing new diagnostics, whether they be imaging diagnostics or lab diagnostics or other types of diagnostics, but those diagnostics come with such a challenge because they create these islands and these silos. And as we heard, breaking down those silos, or being able to transmit information effectively, is such a critical piece in terms of improving patient safety and in clinical outcomes, and reducing that time to diagnosis. As we heard, very clearly defined disease pathways in oncology versus somewhat ill-defined or challenging diagnosis, and ankylosing spondylitis. And that usually has like years to diagnosis. And so it's diffuse. And those are the challenges that are come across. So I admire, you know, the group here from a medical perspective, the IT perspective, and the patient's perspective, all coming together and listening to each other, and being an active participant in making things better. And I think Dr. Sanfilippo has been integral in providing increased quality with regard to electrocardiography. So with that, I really thank everybody's time. So I want to go lead into the questions, and I really would like to start with Joan. And Joan, I think one question from the patient is, what would be the most helpful thing for patients that a medical professional can do when seeking diagnosis?
For me, probably the most important thing that a medical professional could do is to listen carefully and demonstrate in the very first instance that you respect the information that the patient is providing to you. And even for that period of time when you're beginning to hear what they're saying, allow your mind to be open. You come with a vast catalog of knowledge, but set that aside for a moment, because every once in a while, all your protocols and all your averages, 99% of people think this, but there will be a zebra every once in a while amongst the horses. So listen carefully to what the patient is saying. And if there are family members or helpers along the way, also listen to them should the patient not be able to communicate very well. And just take that moment to really set the stage in terms of building trust and rapport. If you don't build trust, your patient will not feel comfortable sharing information, critical information with you.
Joan, I just have just a follow-up question on that, and it was in the chat with regard to your experience was your own personal experience, and your experience was your daughter's experience, that you were potentially an advocate for that. Well, in other experiences, patients may have mental challenges, cognition challenges, and they need an advocate. So as an advocate, would your answer be different, or would you alter that answer?
I would say I actually am a volunteer for the New Canadian Center in my community. So that's exactly what I do with people coming to our small city who are speaking Spanish or Arabic. My advocacy is really to help them navigate a little bit of the system. So that's also what I mean. If you're vulnerable in some way, whether it's language or cognition, think carefully about maybe engaging somebody who can help you walk through this. But still, it's very important that the patient has the capacity to communicate their view as well.
Great. Dr. Sanfilippo, talking to you about or hearing you talk about where you're meeting the patient in a physical space and a doctor's office is really can be somewhat isolating in terms of all the other services around, and now we have different types of services. Does this mean we no longer need doctor's offices, or doctor's offices need to be radically changed? How is that changing?
So we definitely need places where doctors and patients can come together to establish those relationships that Joan has outlined so nicely, that are so critical to everything working. I mean, what makes the whole system work is the relationship, right? And that relationship needs a place, and it needs time to develop. So we will need doctors' offices. We will need places where doctors can engage their patients and have those conversations and those assessments. But my point is that you're quite right. They're isolating. They're isolating for the patient. They're also isolating for the doctor, right? So it would be wonderful if we could bring those encounters into an environment where the doctor can not just see the patient, but can can allow the patient to undertake whatever investigations are required around that office, around that environment. And for the doctor to be able to access information and other doctors who will be relevant to the care. It's also really important. Joan speaking really nicely about this, but there are all kinds of surveys about what patients want from their doctor, right? And they come down to three things, right? They want their doctor to be competent, right? They want them to know what they're talking about and be able to do what they're doing. They want them to be available, but thirdly, they want them to be compassionate. And that word compassionate brings into play all the issue of communication, of understanding, of understanding them, listening to their story, and advocating for them. If in this day and age, the doctors need backup. Okay, no one doctor can do everything for every patient. That'll never happen. So we need to be in places where we can work together, where we can talk to each other, find out without having to wait 3 weeks and for a callback to get help with a patient who's sitting in front of you today. So yes, we need them, but I think they should be integrated into structures where the needs of the patient could be more globally addressed.
And just to follow up on that, and to follow up sort of in the theme of what Joan was talking about is communication. I mean, we have all these new technologies, and here you're saying, and the theme has been about communication, and perhaps you could talk about how you communicate with patients and with potentially their advocates. Like, how do you bridge that medical divide? Because I think you heard from Joan talking about, well, we've got these tests, whatever they mean, or took some while to figure it out, and putting those things in context. And you hear from from the patient's perspective, terms like fear and anxiety, and so if the communication is like the number one, three, or two thing here, how do you as a medical professional sort of bridge that gap in what you're, from your medical language to how you're working with the patient, or conversely, how important is, and subsequent, is a patient having an advocate or a friend there to also hear what you're saying?
So we could talk about that for a long time, but let me say a couple of things about it. First of all, I work in a medical school, as you know, and I've been involved in education of students for a long time. And the thing that has changed most since I was a student is the degree to which we need to enable our students to connect with people of different backgrounds. And that doesn't just mean languages. It means of different ways of thinking, different approaches, different fears about the medical profession. We have to train our students to communicate not just in terms of articulate language, but in sensitivity. They have to be able to recognize that to talk to people who are not like them, don't sound like them, don't think like them. And that's not an easy thing to do. And that means the environment in which they train has to reflect that culture. Okay, so we can't train people in a multicultural, to be multicultural doctors in a unicultural environment. So it starts with training. It starts with understanding that communication is not just words. It's two ways. Its second thing is time. Communication takes time. Okay, and if you are watching the clock and waiting for the little hand to come around for the next patient to come, you can't take that time. The patient will not have the license to say the things they need to say. So we need to have environments where there is sufficient time for patients to feel like they can hear, that they're heard, and for doctors to get everything they need to hear. That means we need to think differently about how we structure how doctors are, frankly, compensated for what they do. Right? If we're on a clock, that changes the way things work. The other, we have to use the tools that are available to us. I mean, Jacques has talked to us about tools that we couldn't have imagined a few years ago. When I started practice, you talk to people one-on-one or you've picked up the phone. We've got all this. Look at this. We're talking to 1,000 people, right? I mean, why can't we have situations where we can where patients can access us? We can talk to them. We can follow up. We can. I now see most of my new patients this way, and then I see them in person, and that allows me to hear what the issue is, understand what tests they need, what they've had done, and then I'm prepared for that first personal encounter in a much different way, and I can do it more quickly. I can see the patient virtually very quickly. Bringing them physically for an appointment takes a little longer, but if I do that one first, it works. And then pandemics helped that way, to be honest. You know, it's forced us into different ways of doing things. So let's use the tools we have available to us to augment that communication. And let's train people and with the expectation that that's what they're going to need to do.
Wonderful. You know, you talk about these new tools and new information, and we have data, you know, an incredible amount of data. You know, I think I read somewhere like a cardiac patient can generate a terabyte of data a week. And by the end in the record, it's like a few kilobytes, like AFib. So, you know, you talked about AI, and AI is everywhere now. It's just used in everything. And there's concerns about it, and there's opportunities with it. You know, can this really be a trustful function right now in the care of people? And you know, is it consistent on the results, or does it evolve? Like, what's the trust level that medical professionals have with it, or patients have with it, or even yourself? How does trust differ in depending on your perspective with regard to artificial intelligence?
Yeah, AI is everywhere for the kids, for example, in Instagram and all of it. But the principle is, what is AI? It's to train a model. So you need somewhere at the end data, trustful data at the end to create this model, bring it in the model, and you have to validate it step by step. That's why I spoke before. When you go to a researcher, he will put everything that he can in this AI system and results coming out. So the principle is, at the end, we need really the specialists, the doctors at the end, on our field now, when we speak, for example, on diabetics, we need the doctors on the field or the people that validate at the end what is the result of this. And it's a training model. So will we have also false results? Yes, sure, it will be trained at the end. But that's why the principle is clear. An AI system will never replace a doctor or a nurse. It will each time be a helping tool, helping to be faster, to have another view at the end, and at the end, you have a new way on thinking. For example, in Luxembourg, we have perhaps also all over the world that you can that you can over the voice recognize symptoms at the ends from. So the principle today is AI is a powerful, helpful system, but at the end we need altogether trustful information at the beginning. In the middle, step by step, train the models and the end, and also from the ethics side to check at the end what is the ethics side. Perhaps a system that works in Luxembourg will not work at the end in Asia because that's another morphology of the body at the end. I'm not a doctor at this side. That Dr. Anthony knows much more about this, but that's the way to go on. But at the end, AI can help us on it. Also, Anthony spoke about patient care. That's one of the major problems that we have today. Most time, what the care people and the doctors have to do is put some text, some data in a computer. But the vocation for doctor care is to speak with the patient. So the way is, how can we over voice at the end help? So that really there's a communication between the doctor and the patient, and directly there is at the end the reports coming up that has a certain consistency at the end that the doctor have to check. So all these models still now exist. You have from Microsoft Copilot. So I know not make now good things about Microsoft, but just there are things coming up. But at the end, you need each time at the beginning people that know the business, that know what happens, that tend to validate things, and then we can go on at the end.
So, you know, with regard to this, there's lots of complexity for a lot of people to understand what you've done and how, linking these systems have been, where have been people in the chat are saying that this might be great or great to pilot, and where were the great challenges for you in either designing or implementing such a system, and how have you seen those, has that, the challenge of doing it and the implementation, has that, seen some effect on patient safety?
Perhaps I was not too clear. It's a 2-year project. We are now in the beginning of the project. At the end, we are in the first phase of the project. But at the end, the technology is not really the problem. The technology can do a lot of things. But at the end, it's really, as I said, that we have from that we bring people together. If you bring a system to a doctor, to a nurse, and they understand nothing, then you lose at the end this scientifics. So that's the first thing. Often what the major problem that you often have is on the legal side. On the legal side, changing procedures on it. That's really the focus that often also on GDPR side at the end, what can I exchange or not? Where is the consent about this? So I think the legal side is the much more the pain for me, the painful side at the end. From the medical side, if you onboard the right person on it and you create really a consolidated team, that it's for me the project is just fun. Sorry for this, but it's fun because I learn every day how a body is built at the end, and other people learn a little bit about how this technology works like, and that's this understanding that we have to do. Really, that people that's everywhere, somewhere, it has not to be the specialized, but have to stand the way that we are doing together. And I say together, not alone.
Wow. Okay. Just looking at the chat, there's a question. I'm going to ask this question to all three of you because I think it's really important. And it's really, how do the panelists, and I'll go in the order. I'll start with Joan again. Suggest the system collect patient experiences or near misses or errors so they can be reduced or eliminated, because we do have patient errors reporting systems, but how can they be improved? And given Joan your multiple experiences, do you have any thoughts about that?
That's an enormous question. And I would say, through my experience as a patient surveyor, probably I can answer from that perspective. The important thing to recognize when errors are identified is to lean into that issue rather than, everyone's going to be a little defensive about it and concerned about, oh, how will this impact me? Did I make a mistake? But as organizations, if you lean into it, I'm getting feedback. Lean into it, collect the information, sit down and figure out what the patient is telling you, what the family member is telling you, and dissect it, and really make a commitment on the organization or even private practice angle to study the issue, dissect it, and develop a plan to repair it. So we have many examples of that. Obviously, hospitals look at this every month, and to take it seriously and not, if you get over being defensive, and work together and engage the patient and their family in that process as well.
Right. Tony, do you feel that some proposed models that you're suggesting would help collect and identify those near misses and address them faster, or?
Yeah, I think an integrated system gives you a better tool to collect and understand what errors are. But when you think about errors, they kind of divide into system errors, human errors, right? And human errors are, glitches and competence. And the whole process is to figure out how your errors, fall out. And the fact is that most things that go wrong are not because people intend them to go wrong or want them to go wrong, or aren't competent in what they do. It's because of a combination of inattention and system error. And if we can make the system work more in an integrated way, that'll cut out a lot, or it'll allow us to identify a lot of those things very quickly. And we need an atmosphere where people aren't afraid of it, as Joan said. Most of these things come up, make us better. Most of the times things go wrong. Um, they make us think and they make us better. But that only happens if you have a process where they're brought together in a way that's thoughtful. I mean, if they happen in isolation, we waste that experience, right? We waste the learning. If they're brought together into the system, we gain from it. So I think integration will help dramatically that way.
And Jacques, is your
Uh,
talking
yes.
about your AI system potential and the way you're breaking down silos? Is that something where it sounded like instead of, I think waiting to find the errors, are we transitioning to proactively looking for them automatically?
Yeah, I will roll back a little bit for what Anthony said, and I'm on the way. If you have human error, for me, is at the end, train people, knowledge transfer. That's something young people learning from old, and vice versa at the end. And on the classic principle, and that's on the digital side, what we normally have to do each time, but it's also for each system, you have to monitor things. You have to make KPI somewhere to check if something's wrong. If there's a problem on it, adapt it at the end and learn about what you have done, how you can change the way on doing things. So with AI at the end, that will also help us at the end. So will we have with AI 100% of results? No, sure not. But at the end, often a doctor has a view on something when he adapt, for example, when he put in some messages, and an AI can at a certain moment give him like an assistant saying, are you really sure that you have done this and this? So really the helpful thing that before he was alone at the end, and he's also a doctor or nurse is often stressed. That's their normal life in a hospital. They have no time, really time at the end. That's the problematic that all of us have at the end. So the principle is the AI is really your assistant. Try to be your assistant at the end, but at the end, the decision has to be done by human at the end, not by the machine. That's my point of view.
Well, that's wonderful. We're getting close to the end, and I'm just going to ask each of you a question, probably in reverse order now to mix it up. More along the lines of more business and implementation perspective. And then I'm just a brief after that, brief reflection before we wrap up from each of you of how you've heard, found today. But I think really a question that's come up in the Q&A is these are great ideas. These are fantastic ideas. It's wonderful to hear from the medical perspective, the IT perspective, the patient perspective, but increasingly healthcare is a business and budgets and how, you need to, people are saying you need to make the case for the financial viability of different types of new programs. And how do we do that more effectively? And so, Doc, maybe from your perspective, when you were working on this, do you have any suggestions for people to think about what needs to be brought forward? And then I'll go to
Yeah,
Tony.
in Luxembourg, for example, the healthcare sector is regulated by the government at the end. So that's one basic thing that we have that other countries perhaps have not. But at the end is you need a strategy from the government side, because the healthcare before you had, and that I'm on the way with Anthony. Before you had when you have been sick, you have to go to the hospital. Today you have the whole ecosystem at home, services around you. So you need a strategy from the government at the end, and you have to work together. That's for me a clear decision at the end, because more and more we will have problems to get doctors, new care people. So we have to bring really at the end people together. Digital ways can help on it, but really is the principle on focus and not to focus too much on long-term decisions. For me, often is make win to win, make small steps to go in a good direction and not think too far away, because they're often with the large problems that will never end.
Great. Tony?
So costs kept coming up in the chat, and when I showed that picture of a big hospital complex, everybody's thinking right away, well, $500 million, you can't build on that. we really need to think more globally about how we're spending money now and capture all of the costs of our separated system. When we develop separate physical entities, institutions, organizations, boards, plants, people, staffing to deliver separated services, we are spending more money than we would if those were integrated services. And when we fail to invest in prevention, we are turning treatable, cheap issues into expensive issues. So, quite apart from the human cost of that, we're paying a lot more to treat things. Would you rather pay to put out a fire of a building or prevent the fire from happening in the first place? And it's a false economy to think that this is wasted money. We've got to look at all of the costs that we're currently using in this disintegrated system and think about what costs could be saved by having integrated systems where we share staffing, we share supplies, we share contracts, we share buildings, we share electricity, and we prevent people from developing conditions that are stressing the system today. That's a difficult analysis, but it's the valid one, because at the end of the day, certainly in our jurisdiction and in most places around the world, we pretend it's all separate pockets we're taking the money from, but it's all coming from the same place. It's coming from the public. It's coming from the costs that would otherwise be going into other aspects of our society. And we need to capture it globally, not in this truncated, parochial kind of way.
Joan, that's great.
I'm I'm going to come at it in a very similar way and from a patient perspective. Think about it, to communicate badly and be dismissive or not pay attention to your patient is time wasted. If your patient isn't connected with you, they won't follow your instructions. If they don't trust you, you've wasted your time. Also, it's not just physicians who can provide a direct care. You can have an integrated approach where there are other people on your team who may be even better communicators. So look at the perspective of a more integrated health system where the communication is optimal with the patient and family members. And that creates an environment where you actually could save money. And I agree completely that if you don't have to wait while your disease gets more and more progressive, and you can have a quicker response, hopefully maybe with AI support, then it's going to end up being a cost saving at the organizational level. So my point is, and it might be my social work background, if you communicate well in the first instance, you will always save resources.
Well, just looking at the time, I really appreciate each one of our speakers talking about their experiences, their insights, and what the future may hold. You know, thinking about that, communication is key, integrated care is key, how we treat each other with respect and understand where they are and where they're coming from is so important. And things that, you know, at Accreditation Canada and HSO, things that we're looking to the future as well. So I really appreciate everybody's time that spoke. I appreciate everybody's time that attended today and put questions in the chat from probably 85 different countries around the world. I appreciate all the engagement that's happened, and I really hope that people really take these messages to heart. So just a few things to follow. There's a survey feedback. There'll be a survey link for feedback. The recording of the webinar, I think, will be coming in about a week. You'll be able to get a copy of the slides and a certificate of attendance. So I just want to leave everybody with one challenge. And that is reflect on one action you can take to contribute to improving correct and timely diagnosis and ensuring patient safety and improved health outcomes. Whether you're a healthcare professional, caregiver, patient, IT professional, someone that's working in, even cleaning the floors, all those are integral parts to a patient experience. And we all dedicate ourselves to that improved patient experience, and we all have a role to play. So I really appreciate everyone's time. Thank you very much. Please go to our website if you have further questions or would like to learn more about our organization. Thank you.